Good evening. Good evening, ladies and gentlemen. Welcome to the Industry Symposium by Hilton Pharmaceuticals. I am Dr. Kifayat Ali, working as Assistant Professor Endocrinology at Mercy Teaching Hospital. Now, to begin the session, I would like to invite the chairpersons on the stage. The first chairperson is Professor Zaman Shaikh, who is a Professor of Medicine and Consultant Endocrinologist at Sir Syed Institute. Sir, please welcome. Second panelist is Dr. Osama Ishtiaq, who is a Consultant Endocrinologist at Shifa International Hospital. Sir, please join us. And the third one is Dr. Gulshad Hassan, a Consultant Endocrinologist. Sir, please welcome to the stage. Join us. Now, we would like to introduce our speaker for today's session, which will be about the current of life. The speaker for today's session is Professor Khurshid Khan. Professor Khurshid is a Professor of Medicine and Endocrinology, Head of Department of Medicine and Endocrinology at Fatima Memorial Medical and Dental Hospital. He is a past president of Pakistan Endocrine Society and a faculty member of West Virginia University. Sir is a diplomat of American Board of Endocrinology, a fellow of American Board of Endocrinology, and working as a consultant physician and at Doctor Hospital and Farooq Hospital, DHA. Sir has got more than 50 publications and an avid international and national speaker. Sir, please join us on the stage. Sir. Thank you.
Thank you very much, Dr. Kifayatullah, for a very generous introduction. And it's always an honor to come speak on this prestigious forum. And what can be more prestigious than Pakistan Endocrine Society itself, with all the faculty, consultants, fellows, and members of this college being here. And it's good to see that much attendance that late, even at 9:30 or so. So thank you for all this, for the invitation to the scientific committee for this. This is, as you know, is a corporate session. Can I have a mic? Mic है? किसी के कोई मुझे mic मिल सकता है move करने के लिए? So ये वाला mic दे दो यार सामने से. So let's start with this. Slide change रही है जी और laser अच्छा. The topic is a shared multidisciplinary approach to erectile dysfunction in men, and titled as Current of Life. This just reminds me of this patient I saw a few months ago. He was about 70 years of age, and he came to my clinic. He had other medical issues, diabetes, hypertension, etc. So he said that he had erectile dysfunction, and I addressed it, and by the time he was leaving, he made a comment. He said, you know, Dr. Sahab, I feel like कि जो मेरे अंदर लाइफ का करंट है वो खत्म हो जाता है when I'm unable to do this. So talk was being said those days, so I said, let's name it the current of life, and then we'll talk about this. So the session objectives are: recognize the erectile dysfunction as early marker of systemic disease, apply a collaborative multidisciplinary approach to the diagnosis and management, and select appropriate treatment based on erectile dysfunction severity. How do we define erectile dysfunction? Once in a while, someone not having proper erection during sexual intercourse, of course, is not erectile dysfunction. So erectile dysfunction is defined as the persistent inability to attain and maintain an erection sufficient to permit satisfactory sexual performance. And a 3-month duration, the symptoms have to be there at least for 3 months for someone to say that, yes, you do have erectile dysfunction. Globally affects 1 in every 5 men. 52% of the men between the ages of 40 and 70 years suffer from this disease. In Pakistan, there's a diverse data. I was able to pull a couple of studies. One was done in Karachi, and this mild erectile dysfunction in that study, which was reported, was 17.1%, mild to moderate was 37%, and moderate was 21.7%, severe was 20%. This was done in diabetic patients in Pakistan. So what is andropause or andromenopause? It's basically the drop in level of testosterone in our patient population. So the testosterone, we know it declines by 1 to 1.6% every year after the age of 35 in most of the individuals. So at certain stage, those individuals meet the criteria what we call as late onset hypogonadism, androgen deficiency, and testosterone deficiency syndrome. Are basically the deficiency in individuals where the level is dropping significantly more than their age group. So everyone gradually, as life goes on, 60s, their testosterone levels are not the same as but in the 30s or 40s. In 70s, the levels are lower than 50s and 60s, but they still maintain themselves. So if the range is not well maintained, then that's when we give them testosterone deficiency syndrome. The title are the late onset hypogonadism. So for the diagnosis of this to be established, at least there have to be 3 symptoms. There has to be decreased libido, low morning erections, erectile dysfunction, and then this dysfunction has to be tested with low levels of testosterone. If someone has all the 3 symptoms but normal testosterone, then the cause for those symptoms is somewhere else, not with the low testosterone, because testosterone have to be low in these individuals for them to be labeled as testosterone deficiency syndrome. And the last line is most important. We all know men with erectile dysfunction and low testosterone are at risk of cardiovascular disease and all-cause mortality. Very briefly about the physiology of erectile, how this sexual function, how the erection happens. This happens from combination of all these factors: psychogenic, neurologic, vascular, and hormonal factors. So psychogenic erections are triggered by neural impulses originating in the cerebral cortex area and then relate to the thoracolumbar erection center. अगर कोई लेजर है तो मुझे दे दें. Barely works. चलें खैर. There's a sexual center in the spinal cord, thoracolumbar erection center, and then the reflex actions are created by tactile stimulus. So one is the psychogenic erections, which are through the thoracolumbar region. The second is through the tactile stimulus, and that's in the sacral erection center. So from these neural impulses flow to the pelvic vascular bed, redirecting blood to the corpus cavernosa. So the real the puzzle is how the blood goes to the corpus cavernosa there. So we all know from these neural impulses, from these stimuli, there's more production of nitric oxide. That leads to more production of cyclic GMP, which relaxes the smooth muscles within the vasculature. And as a result, there's more blood flow within the penile arteries there. So the absolute prerequisite for penile erection activity are an adequate arterial inflow to provide a constant source of intravascular oxygen and sufficient nitric oxide synthase to generate nitric oxide. Nitric oxide job, like earlier I said, it increases the level of cyclic GMP, cyclic guanosine monophosphate, which relaxes smooth muscles and leads to more blood flow, penile engorgement, and erection. And for all this to happen, the testosterone has to be there. Patients cannot generate enough nitric oxide within the endothelium of the vasculature within the penile area unless there's enough testosterone present within the circulation. So testosterone is necessary for maintenance of intrapenile nitric oxide synthase levels, and low levels are we know that in diabetes we tend to see low levels. Smokers, we see low levels there as well, which explains the higher incidence of erectile dysfunction in individuals with these diseases. So the drug what we are talking about, phosphodiesterase 5 inhibitors, what they primarily do, the cyclic GMP is broken down by the enzyme phosphodiesterase type 5. So they block the phosphodiesterase 5 enzyme and then lead to the higher level of cyclic GMP, which leads to prolonged action of cyclic GMP within the blood vessels and leads to more relaxed muscles, more inflow of blood, and as a result, more engorgement of vasculatures within the penile tissues. But before you label anyone as having really an organic issue with hypogonadism or psychogenic issues there. You need to look at, this is very important slide from that standpoint. You need to look at these factors. Someone who has sudden onset, early collapse of erections, sudden onset of ED, early collapse of erection, good quality or better spontaneous self-stimulated or early morning erections are triggered by psychological events. So that erectile dysfunction is really not organic. You need to work on the psychological part of that. That part needs to be addressed. But on the other hand, if there's a gradual onset, normal ejaculation, normal sex drive is there, but so in those patients, you need to look for the underlying cause. Anytime a patient with erectile dysfunction comes to me, my main thing is to see if it is psychologically triggered or is triggered by what is the other common cause for erectile dysfunction? Psychological तो we see it many times with that. What do you think? दूसरी common cause क्या? Aside from organic, from the list of organic, I will come to. Medications, these patients are on multiple medications. So the second part is to go through the list of medications what these patients are taking and see if any of these medicines, antihypertensives is a list of medications, antidepressants, we all know SSRIs and others, they play a role, antipsychotics, hormone agonists or antagonists, they play a role as well, anti-Parkinson's drugs. So all those drugs, you can go down the list and there's a slew of whole lot medications which can cause erectile dysfunction. So it's important to go through that before we start working these patients for any organic cause for erectile dysfunction. So in organic causes, the vascular, neurological, hormonal medications, those things are very important there. And in other, psychological depression, performance anxiety. Performance anxiety is also something we tend to see in younger adults as well, with very normal or high levels of testosterone. They get married, they cannot perform for next 3-4 days, and they just go into psychological trauma, and this system shuts down. The psychological system shuts down, that psychological component goes away. So in those cases, we see even the young adults with normal vasculature, with no history of any comorbs, not on any medication, just based on psychological suppression, they are not unable to have normal sexual intercourse. So when we deal with patients with erectile dysfunction, the key is a detailed medical and psychosexual history on those patients, identify the cause for erectile dysfunction, very focused exam on penile deformities, prostate disease, signs of hypogonadism, and cardiovascular and neurological status on those patients. And then obviously if we feel there that these patients, other factors we don't see them, and we feel like it could be just triggered by hypogonadism, of course we need to go down the line, work them up for testosterone, as you see in the right lower column, and LH, FSH, and prolactin levels as well. But at the same time, if you look at the box on the right side, these patients are at risk for cardiovascular disease. You need to look at their glucose, their lipid profile, because we know that if they haven't been diagnosed previously, they may well have it. So that could be another factor which is causing all this. So when the treatment for erectile dysfunction will come in detail. The cornerstone of erectile dysfunction these days is phosphodiesterase inhibitors, and there are many of them available. In the past, we have been using intracavernous injections of L-prostadil or suppositories of L-prostadil, and other devices have been used in there. But right now, the most convenient and the first line the drug therapy is the phosphodiesterase inhibitors in these patients where there's an appropriate indication for treatment. So my question is, why asking the patient regarding erectile dysfunction, or why diagnosing erectile dysfunction is important? The reason is erectile dysfunction may signal underlying diseases, diabetes, hypertension, dyslipidemia, coronary artery disease, depression. So that's one part. And second part is, yes, someone with erectile dysfunction may have low confidence, anxiety, decreased self-esteem, decreased quality of life. So that's why this has to be addressed as well. That's an important part there. And remember, this is a macrovascular disease. In many patients with cardiovascular disease, you are going to see erectile dysfunction first before you see acute MI in those patients. So that may be an indication. If one of my patient complains of erectile dysfunction to me, and I know it may be the vascular reason in that patient, there may be vasculopathy because of diabetes, especially for diabetic patients. Vasculopathy from diabetes, I usually tell that patient, fine, I do address the erectile dysfunction, but at the same time, I send that patient for some kind of testing for the cardiovascular disease, maybe just a simple stress test on the treadmill if the patient can walk, those kind of things to see what is the cardiovascular endurance level of this patient. So it's the predictor of cardiovascular disease. 3 to 5 years presents often 3 to 5 years prior to the onset of cardiovascular disease in patients. Atherosclerosis can affect the penile arteries earlier than coronary arteries. So as a matter of fact, if you're a patient of ED coming in, it may be opening, showing you the window in the future to the physician that 3 or 4 years down the line, this patient may end up with a major MI. So you need to look at the cardiovascular health of the patient along with the erectile dysfunction in that particular patient. Peripheral vascular disease is another disease, another condition which is associated with this. There are multiple medications, we'll come to that. Tadalafil is one of those medications, and it is used in benign prostatic hyperplasia as well. We know that phosphodiesterase 5 inhibitors, they are used in pulmonary artery hypertension as well, and they are helpful. So multiple uses of these drugs. But the safety, always we say, do no harm. The safety comes first in these patients. So co-administration of nitrates and sildenafil or other phosphodiesterase inhibitors increase the risk of potentially life-threatening hypertension. Patient can collapse, patient can have syncopal episode if used with other nitrates as well, and sometimes even the non-nitrates, anti-anginal drugs, even beta blockers, you need to be very careful and see how patient is doing with those drugs. What is the blood pressure like before you prescribe any of your diabetic patient or hypertensive patient any of these drugs. So I think we have talked about coronary artery disease, but sometimes what happens, let me ask audience this question. अगर आपका एक patient आता है जिसे erectile dysfunction है, उसे MI हुआ है साल पहले, तो what do you do for that patient? Anyone from the audience? क्या कहते हो उसे, अगर उसे acute MI हुआ है साल पहले? 6 months का आप कहते हो. तो do you do anything on those patients के आप कहते हो नहीं आपको तो 1 साल हो गया, it's more than 6 months, तो ठीक है, you are good enough, और अब ठीक है आप यूज कर लो आप phosphodiesterase 5 inhibitors. Symptoms देखने पड़ेंगे, चलें. That's certainly, I think that I'm talking about on the same lines. There's always a concern that in patients with ischemic heart disease, what is the functional status of the heart? Of course, you give him one of these drugs, phosphodiesterase inhibitors, there's a good erection, there's a good sexual activity, there's a good exertion because of that, but does he have good enough heart to cope with all that? Isn't he going to end up, if he's compromised from unstable angina standpoint, is he going to end up with another MI at that time? So that's why as a treating physician, it's important to look into that. These patients need proper evaluation regarding their fitness for phosphodiesterase inhibitors, which could be just a simple question from you, asking the physical activity of the patient, and if in doubt, always good to check with their cardiologist, send them for a stress test, like I said, just simple exercise tolerance test. A simple test which I can tell you for, because how many of you are general practitioners? So a simple test what you can do sometimes, instead of putting the patient through a whole lot, if the cardiovascular status is good with 4 meds. 4 meds means if someone can climb, well 4 meds is more on the treadmill, but if someone can climb 4 flights of stairs upwards, 4 मंजिला building चढ़ के वो चला जाता, उसे chest pain नहीं होती, he doesn't get severely short of breath, then that means your patient is good enough from cardiovascular standpoint. So that is of always a concern that when you prescribe meds to patients with ischemic heart disease, you do need to look into this as well. The concurrent use of nitrates clearly contraindicated, and then We already talked about all this acute coronary ischemia, congestive heart failure, complicated multi-drug, antihypertensive meds. So needs to be evaluated. So this is not something which should be very lightly prescribed. You need to go through all the steps before you can prescribe that. Which of the drug is better than the other? Sildenafil, tadalafil, vardelafil, or venafil? Anyone? Can anyone? It's okay. इनका डॉक्टर साहब ने कहा जी कि शॉर्ट ड्यूरेशन ऑफ एक्शन है, बिल्कुल सही. 15 to 30 minutes ऑफ एक्शन है. इट लास्ट अप टू 6 hours टाइम. तो ड्यूरेशन भी एक्शन है, ऑनसेट एक्शन भी है. लेकिन कपल हैज गॉन for a weekend outside, and they don't want to time it. They just want the time to come. So I think in those cases, maybe sildenafil may be the better option. So all these things, sometimes there are concerns regarding the side effect in these patients. Sorry, I meant tadalafil, not sildenafil. Tadalafil may be better option because a much longer duration and 24 to 36 hours. But sometimes when the side effect is a concern, you look at which side effect patient normally gets. You get side effect from one medication. Well, there can be different side effect from one versus the other one. Some have fewer side effects, others can have more side effects. So you need to look at all that. Very good point. So priapism is one of the side effects there. If the priapism is going to happen, that will happen even with the drug which has duration of only 2 hours. So not necessarily with the drug of 36 hours. Yes, once the priapism is there, then certainly this is a surgical emergency that needs to be addressed. I have seen one case of priapism back in 99, I think, from sildenafil. While I was in Miami, this patient came with priapism of about 2 hours. Normally 4 hours can be very dangerous when it comes to penile structure. So the urologist had to come in, put the cannula into the corpus cavernosa, drain all this with a normal saline, drain all the blood from there enormously. So that can be very devastating complication, but luckily it's very rare. I have seen only one case in my life. So and the reason is, that's why I keep highlighting drugs have to be prescribed to the right patient for the right kind of indications there. 36 hours? And you're saying that your question is? But you're not giving that drug daily to that patient. This drug is on demand, given only when needed. So if someone needs it over the weekend, that you can give it, that's not a problem. It depends on demand. So I think let's move on further from there. And yes, now my question is, what happens? You prescribe one of your patient phosphodiesterase inhibitors. This is a good question. आज तो क्वेश्चन मैं आपसे पूछ रहा हूँ. आप phosphodiesterase देते हो पेशेंट को, उसको वो कहता है डॉक्टर साहब असर ही नहीं हुआ, फायदा ही नहीं हुआ, और आप समझते हो he was a candidate for one of those 5 phosphodiesterase inhibitors. So क्या करते हो? What is the next thing you do then? जी? I'm sorry. Acha, so normally what you can do, the recommendations are, if someone is not responding to one phosphodiesterase inhibitors, you can maximize the dose of that one and see how it does. If still there's not improvement, then you can switch to the second type of phosphodiesterase inhibitors, because the studies have shown this response. There can be response from one agent while the patient was not responding to a different agent of the same class in phosphodiesterase category. So that's one part. So what if your patient did not have any, a patient comes to you, says, still, doc, I still need some help from you for erectile dysfunction, but phosphodiesterase are not working for me. What do you do then? Okay. With combination? one as like one agent. So patients who are not responding to that earlier, I said L-prostadils could be could be an option for those desperate cases as well in those patients. So the key takeaways from this talk is ED is a erectile dysfunction is a treatable condition, requires accurate diagnosis. The best treatment is the one which is best for your patient, and the phosphodiesterase are the first line therapy for erectile dysfunction. What is the missing link here? क्या missing link है इसमें जी? Despite the high treatment success rates of 78%, most of the patients, only 10% of your patients with erectile dysfunction get the treatment. And the taboos is, there's taboos about asking for this treatment, physician communication gap, lack of awareness. So those taboos have to be have to be taken care of, have to be addressed. Just I will end my talk with this slide. There is a survey of 500 patients over 50 visiting their over the age of 50, visiting their urologist. This was published in journals of internal medicine. So 44% reported some degree of erectile dysfunction. Almost 50% of those patients, half of those patients, which is 44%, they had erectile dysfunction when they visited their urologist in the office. But out of them, only 10% had discussed with their physician when they were asked what was the reason for that. Embarrassment, asking about this, exposing themselves was a concern to them. Some people thought was natural part of aging, so let's not talk about this. Some did not know if the urologist or endocrinologist was aware of dealing with this, and some others were not interested. So that was the data. So I think I will stop here, and I thank you all very much for your attentive listening.
Thank you, Professor Khurshid, for such an elaborative talk. Now it's time to take comments from the worthy panelists, starting from Dr. Osama Ishtiaq. Dr. Gulshad Hassan.
Thank you very much. I think it was a very detailed and interactive discussion by Professor Khurshid, and very important topic, which normally many patients actually don't discuss with their physicians, And I think he has discussed in detail the different kind of medicines we should use. But I can share that some experience that there are some, before we treat a patient for erectile dysfunction and he doesn't have got any other reason for that, like high prolactin level, or even sometimes the TSH is high, thyroid dysfunction is there, which can also cause some raised prolactin, and if obesity, which reduces testosterone levels. And if you treat those conditions, even hypopituitarism, the patient's erectile dysfunction does improve. So keep in mind these things also, that patient has to look for that, for those diseases. If they are there, then patient should be addressed and treated for that. So before it is being treated with the drugs. In my experience, I think the patients have improved without the use of drugs and with the addressing those problems.
Professor Zaman Shaikh, sir, for one line.
Thank you very much. Actually, it's very heartening to see our young endocrinologists. They are taking maximum part in these academic sessions. So I congratulate our young generation of endocrinologists. Now, talking about the speaker, excellent talk by Professor Khurshid, I have got 2-3 points. Number one, duration. Now, number one drug is PDE5 inhibitors, no doubt. Now, there is competition between these drugs. Number one, but competition among these drugs. So, main difference is time. 15 minutes may ready. 36 hours, lasting for 36 hours. This depends upon the situation and type of the partner one is meeting. 15 minutes in house may be very dangerous because only 15 minutes. And at the time when child is start weeping. So 15 minutes gone in taking care of their child, small child, rather than big child. So, so 15 minutes may be dangerous. On the other hand, 36 hours may also be dangerous. Why 36 hours, full ready, and anything can happen between for this 36 hours. So one choose the partner and then choose the drug. Number two, what after PTE5? Now PTE5 is number one, and I may say last number as well. Number one and last, because there is darkness after PTF. 100% patients they are not get benefited with PTF. So after PTS, one has got Kifayat injection, vacuum devices, and some surgical procedures. All are not perfect, very expensive, maybe damaging. So these are not perfect drugs, PTFI. We still need new drugs. अच्छा दूसरी बात ये कि फाइजर ने वियाग्रा निकाली थी 92 में 8 साल FDA ने लगा लिए सोचने में कि क्या करें. Even then after 6 years they passed. अब पाकिस्तानी फार्मास्यूटिकल कंपनी को जोश आ गया. They went to ड्रेप सेड नहीं भाई ये मिसयूज होगी. अभी अफसोस की बात है कि ड्रेप हमारे यानी ईमानदार इतने आने से हमारे पाकिस्तानी मर्दों पे ब्लेम लगा रहा है कि ये मिसयूज होगी. तो ये मेरे ख्याल में तो हम कई दूसरे मुल्कों से बेहतर हैं ईमानदारी में. गॉड नोज बेटर. तो कहने का मकसद ये कि जैसे ही रास्ता खुला अचानक ये सारी ड्रग्स एकदम जैसे बंद टूटता है तो आ जाती हैं, सारी आ गई हैं. अच्छा एक मैं आखिरी क्वेश्चन कहता हूँ कि कमेंट करता हूँ क्वालिटी ऑफ लाइफ. अब देखिए ना क्वालिटी ऑफ लाइफ एक तो घर के बाहर होती है. सी द डिफरेंस बिटवीन दुबई एंड पाकिस्तान आउटसाइड हाउस. क्वालिटी ऑफ लाइफ एवरीबॉडी नोज. कानून कैसा है और डिसिप्लिन कैसा है, वीआईपी कल्चर नहीं है कुछ भी. दूसरा उससे भी ज़्यादा बेहतर है क्वालिटी ऑफ लाइफ इनसाइड हाउस. कहते हैं ना गो ईस्ट एंड वेस्ट, होम इज़ द बेस्ट. अब घर की क्वालिटी ऑफ लाइफ जो है वो इसी चीज़ पे डिपेंड करती है जिस पे खुर्शीद साहब ने रोशनी डाली है. अच्छा आप फैमिली फ्रेंड के साथ किसी फैमिली फ्रेंड से मिलें अपनी फैमिली को लेके और एक अजीब तमाशा देखें कि उनकी बेगम बार बार अपने ताजदार की पगड़ी बार बार उतार रही है बातों बातों में. वो कहता है ये, वो कहती है नो. जो भी मतलब तंज करती है हर लफ्ज पे तो आप अलर्ट हो जाएं और अपने दोस्त को मशवरा दें कि भाई दिस इज अब बॉइलिंग पॉइंट आ रही है. क्योंकि जब इंसल्टिंग शुरू हो गई दूसरों के सामने means something suspicious. So please better to send your husband, your person to Professor Khurshid. Thank you very much.
Thank you, sir. We are short of time now. Final comments from Dr. Osama Ishtiaq, sir.
डॉक्टर जमान साहब के साथ बैठ के बात करना बहुत मुश्किल काम है. Thank you, Dr. Khurshid, for excellent talk and very comprehensive. Almost, yes, you have talked almost everything regarding to DED. And the ED is not always psychogenic. Sometimes there are organic causes as well. It is one of the commonest causes of ED as well. But one thing we see, young patients में ED का cause different होगा and compared to those patients who have organic. Patients who come with the ED sometimes do have other organic disorders like diabetes. Diabetes is very common and ED is one of the risk factors for heart disease as well. Thank you.
Thank you. Thank you, sir. With this, we conclude the session for today. Now it's time for dinner, which has been arranged at Chinar Hall. So you are all requested to attend the dinner. Thank you.